Yes. Good evening, friends, to this episode of IJMPO Talks. As you are aware, every Tuesday, 8 p.m., we invite an expert and request them to talk with you about a specific topic. The expert gives a talk. Everybody is on mute mode till the talk is over. You keep on writing your questions in the chat box. And once the talk is over, the expert will answer your questions one by one. Today, we have with us Dr. Hari Menon, who is a senior medical oncologist, an ex consultant in Tata Memorial Hospital, and now working in Bangalore in Satacare Hospital. All of you must be knowing him very well, and today he'll be talking with us about high-grade lymphoma management with special emphasis on diffuse large B-cell lymphoma. With that brief introduction, over to you, Hari. The students are waiting for you.
Yeah, thank you. Thank you, Padmaj. Thank you for this opportunity. And it's always a pleasure to be on a teaching platform. Initially, I was given the talk of high-grade lymphomas as a whole, and I felt that that was too large a topic to be covered in one go. So I thought I would split the various high-grade lymphomas and also deal with the other lymphomas sometimes given the opportunity. So today I chose the one that is most commonly encountered in our clinical practice, which is the diffuse large B-cell lymphoma. And what I would address today primarily would be the frontline management and what we need to understand about diffuse large B-cell lymphomas. With that in mind, let us go through with the talk, wherein I would allude to some of the molecular aspects of diffuse large B-cell lymphomas, why we need to treat it the way that we need to, and also how we fine-tune some of the treatment aspects to improve outcomes in diffuse large B-cell lymphomas. So with that, I would say diffuse large B-cell lymphomas, they are, when you look at morphology, it is unmistakable. It just gives a monotonous kind of a picture, sometimes indistinguishable from various different forms at the molecular level. The morphological picture is more or less the same, irrespective of what the underlying molecular abnormalities might be. So they are basically large cells with a loss of follicular architecture, and they are chemosensitive, uniformly chemosensitive. Very rarely do you encounter a lymphoma that does not fully respond in some way, at least, to chemotherapy. And the clinical outcomes and the molecular features are extremely heterogeneous. And we do understand that this heterogeneity results in, has an impact on the outcome, which are again multifactorial. And it would again be erroneous for us to attribute all the differential outcomes for these diffuse large B-cell lymphomas purely based on its molecular makeup. So what have we learned about diffuse large B-cell lymphomas? We do understand from basics that histology matters, the stage of the lymphoma matters, the volume of the lymphoma also matters. Many a time, the site of the lymphoma, where it is located, matters. And what we do in the bedside, which is the IPS score, has stood the test of time for us to be able to determine and prognosticate how a particular patient would behave to one standard line of therapy. We also know that as the age advances and the deterioration of the performance score and association of other comorbidities will affect the outcomes of the lymphoma. And of course, the physician who has a more discerning approach is likely to provide a better outcome for such patients. So understanding the disease is quite crucial. Therefore, what has been the impact of standard chemotherapy, and what has really rituximab done in diffuse large B-cell lymphoma? I'm jumping straight into the to the main aspects of the treatment of diffuse large B-cell lymphoma, because I do understand that I'm talking to a learned audience. So when let us go back to the data that was looked at, which tried to improve on the outcomes of standard CHOP regimen, which has been in existence for more than 3 decades. There were attempts to actually improve the outcomes in these patients by increasing the intensity of chemotherapy, increasing the number of chemotherapeutic agents used for the treatment, and also alternating between non-cross resistant drugs. But what came about from this large study, which looked at multiple chemotherapeutic protocols with a significant number of patients enrolled in the studies, that you clearly see that there is really no difference in the outcomes for such patients. But having said that, we do also take away some aspects from the outcomes in the patient, in that I would like to say that when they were using intensive chemotherapeutic protocols for all diffuse. It also included other subsets like the primary mediastinal B-cell lymphoma, which is also a high-grade lymphoma, which we now today know is a distinct subset, and the MACOB regimen, which was used in for those patients in which MACOB regimen use, and those who had primary mediastinal B-cell lymphoma did have a better outcome, thereby saying that there was some benefit of intensification of therapy in this subset of patients. But largely, the diffuse large B-cell lymphoma did not benefit with more intensification, and CHOP stood the test of time. But then the addition of the paradigm shift in the management came with the addition of rituximab. The GALA LNH 98.5 study, the 7-year survival clearly demonstrated a consistent benefit, both in terms of progression-free survival and overall survival, which was sustained for the in favor of the R-CHOP arm. So we do understand that the impact of adding rituximab to R-CHOP and similar agent in this British Columbia study also clearly demonstrated a distinct benefit for rituximab, and thereafter it has become the standard of care for all diffuse large B-cell lymphoma and for other lymphomas who harbor the CD20 positive B-cell lymphomas. So the outcome of all patients with diffuse large B-cell treated with the R-CHOP protocol in the British Columbia, which is one of the largest study and the longest follow-up, clearly demonstrated a benefit for all subsets, irrespective of the stage. But as would be expected, the limited stage disease patients tend to do a lot better and tend to derive greater benefit. And this is only intuitive that they should derive benefit, and we know that early stage disease do well. So approximately 60% of patients will be cured with the standard rituximab plus CHOP regimen. More favorable outcomes are seen in patients with limited stage disease. Patients who remain event-free at 24 months have recently been shown to have an overall survival comparable to the general population. So what we call as a rule of 24, and also the importance of optimizing frontline therapy has come to the fore when we treat diffuse large B-cell lymphomas. So the outcome of patient diffuse large B-cell lymphoma, let us put it this way. So when we treat all comers with diffuse large B-cell lymphoma, we would expect about 50 to 60% to be already cured with a previous chemotherapy. And about 20 to 30% tend to relapse after having achieved a CR. And we do understand about 5% do not have a complete response and remain in partial response and are likely to relapse more than not down the line. And about 15 to 25% are refractory to any chemotherapy. So when we look at these 50% subsets who are cured with the standard therapy, there is really nothing more that we need to do for such patients to improve their outcomes. But it is important to identify who are these subset of patients who are likely to do well. And these subset of patients do not really require anything more than the standard R-CHOP regimen. It is for the other three subsets that we need to identify these subgroups a little beforehand so that we can put our efforts to actually improve outcomes in this group. So how do we understand that? So let us look at digging deeper to understand the variability in responses to diffuse large B-cell lymphoma. Now we do know that the International Prognostic Index has stood at the test of time, and it is a very useful tool at the bedside to actually prognosticate diffuse large B-cell lymphomas. And this has, as the curves show, there's a very nice playing of the curves depending upon the higher the IPS score, the lower the survival in diffuse large B-cell lymphoma. However, the IPI does not really capture the molecular heterogeneity of diffuse large B-cell lymphoma. So if I will allude to the first few slides, which I said that it is not always the molecular heterogeneity that will determine the outcome of diffuse large B-cell lymphoma, although we know that there are subsets in these groups who tend to do poorly on the long run. So this was the first attempt. I mean, there was the Alizadeh's attempt in 2001, a Nature publication, and then subsequently several groups came out. But generally, I would like to take up this slide for demonstrating clearly that there were three definite subsets based on gene expression profiling that determined subgroups of most of the subgroups of diffuse large B-cell lymphoma, and they fell into the category of in terms of the gene expression into the activated B-cell type, the germinal center cell type, and a distinct entity known as the primary mediastinal B-cell lymphoma. And of course, on either side of we had some group which were unclassified. There were a few with atypical, and of course we know the distinct Burkitt's lymphoma that we see in which has its own distinct expression profiling. But we don't need to have a gene expression profiling for us to determine a Burkitt's lymphoma. So how do these lymphomas emerge? And that is the cell of origin, which is indicative of distinctive biology, which could influence the outcomes for this. So when we look on the left-hand side, the germinal center B-cell lymphomas generally arise from the centroblast, and then they may come up to the centrocyte stage 2, and they have distinct gene signatures that with distinct mutations that are noted over there. But beyond that, that is the centrocyte, which some of them go into apoptosis, some go into memory cells, and then you have the plasmablasts. And beyond the plasmablasts are the lymphomas that arise from there are the activated B-cell lymphomas, and they are dependent upon distinct pathways and distinct. There are distinct pathways that are allowing for its sustenance, and they are entirely different forms of lymphomas, actually, even though they are bracketed under the subgroup of, under the category of diffuse large B-cell lymphoma. Similarly, once the B cell goes into the thymic, the lymphoma that arises from, there are the distinct primary mediastinal B-cell lymphoma, and they too have their distinct gene signatures. So when you look at the GCP subtype, you have the BCL2 translocation. You have the MYC translocation that is common, the EZH2 mutations, the BCL6 BSC1 mutation, and the PTEN deletions. While in the ABC diffuse large B-cell lymphoma, you have predominantly the nuclear factor kappa B pathway, NFK kappa B pathway, which is perturbed due to the mutations, especially involving the MYD88, the CD79B and A mutation, the CARD11 mutation, BCL2 amplification, and the PRDM mutation, which I will allude to subsequently. And we know that the primary mediastinal B-cell lymphoma is a distinct entity, which I will not discuss too much in this talk, and hopefully in another talk down the line. So the gene expression defines molecularly, clinically distinct subgroups. And when we look at treating these patients primarily based on the gene expression profiling, we understand that they are subset with the primary mediastinal B-cell lymphoma with the same kind of a treatment, doing distinctly better than the germinal center B-cell lymphoma, and also the ABC subtype, the activated B-cell diffuse large B-cell, which does worse than the diffuse large than the germinal center B-cell lymphomas. But we do understand that all the curves are lifted upwards the moment that we add rituximab to the regimen. But still, the impact of the subgroup does prevail in terms of even when you add rituximab to this group. But definitely the curves, like the activated B-cell lymphoma curve, tends to move up a little bit when we add rituximab to the regimen. So we do, while it's difficult for us to understand what is the germinal center based on gene expression profiling, we do have, we do resort to immunohistochemistry to determine, though it is not exacting and the concordance rate may not be as good, but still it's a useful way to sort of identify a good measure of patients and categorize them into the ABC and the GCB subtype. And this is based on about four markers, which is primarily looking at CD10. If it is CD10 positive, it's a GCB. If it's a CD10 negative and BCL6 negative, it's a non-GCB. At the same time, then we resort to the third marker, which is third and the fourth, third marker, which is a MUM1. If you have CD10 negative, BCL6 and MUM1 positive, again, it's a non-GCB. And when you have MUM1 negative, we again call it a GCB subtype. So coming to the insights into the biology, how do these things behave like the way that they need to? So basically, in the ABC subtype, the biology has been elucidated rather well, and basically in the core of this is the inactivation of the BLymph1, which is actually a master regulator of the plasma cell differentiation. So this causes a constitutive activation of the oncogenic nuclear factor kappa B signaling, and also there is a constitutive activation of the B cell receptor signaling. And what happens is, at the core of all this is the inactivation of the BLymph1, which is actually mediating plasma cell differentiation. It also influences the termination of B cell differentiation gene expression, such as the SPIB and the PAX5 and OCT2. And all these are sort of as a result of several other processes, which includes inactivating mutations of the PRDM1, which I alluded to earlier, which is seen about 25% of the patients. It also includes the gains and amplification and overexpression of transcription factors that represses the BLymph1. And thirdly, there are also secondary to chromosomal translocation that affect the BCL6, which deregulates PRDM1 and BLymph1. So what we see is a constitutive activation of the oncogenic NFK kappa B signaling pathway, and this results in gains or loss of function mutation affecting upstream members of the NFK kappa B signal cascade, which includes the ITAM mutations of ITAM, chronic BCR signaling, mutations of scaffolding protein, particularly CARD11, which has an impact in terms of responses to standard therapy, gain in function of MYD88, which has come in a big way, and the understanding of the MYD88 not only in diffuse large B-cell lymphoma but several other B-cell malignancies has emerged in the last 2 decades. There is also the inactivation of the ubiquitin modifying protein, which is A20, which is again a negative regulator or NFK kappa B. So, in a nutshell, we have alluded to much of the pathways in ABC, which is predominantly perturbing the new activation of the NFK kappa B pathway, whereas in the GCB, which emerges from the centroblast and to the centrocytes, there is predominantly histone modifications which include the EZH2 mutations. There is a block in terminal differentiation, which is the BCL6 expression is EZH2, again secondary to BCL2 expression, BCL6 expression and EZH2 mutation, and also activation of the mTOR pathway and signaling cascades also which are perturbed, which includes deletion of PTEN or loss of the PTEN, and also the cell cycle activation, which blocks apoptosis, which includes the MYC and the BCL2 translocations, which we commonly see in the double hit lymphomas. There is a chronic BCR signaling pathway, and that becomes one of the potential pathways that can be perturbed for benefit, which I will allude to later, but in some of the more larger studies which are conducted with ibrutinib. So there are, besides the molecular signals, there are certain stromal gene signatures too in diffuse large B-cell lymphomas. And this was an elegant study from Lenz's group, which looked at 3 gene expression signatures, which were termed as germinal center B-cell stromal 1 and the stromal 2, which predicted survival both in patients who received CHOP and patients who received R-CHOP. So the stromal signatures reflected mainly the extracellular matrix deposition and histiocytic infiltration, and the stromal 2 signatures reflected tumor blood vessels, which generally carried an unfavorable prognosis. So what came out of these analysis of this was that survival after treatment for diffuse large B-cell lymphoma was influenced by differences in the immune cells, the fibrosis, and also angiogenesis in the tumor microenvironment, all having an adverse outcome to one standard therapy. Similarly, we do understand MYC gene rearrangements are associated with poor prognosis in diffuse large B-cell lymphoma, and we know that the patients who are MYC positive tend to have an inferior outcome. And also we know that there is a propensity for the CNS involvement for those who are strongly MYC positive. Thereby saying that these patients would require some sort of CNS prophylaxis. So then comes the last, the newer entity, or not say the newer entity, but which has got a lot of attention in the recent past, which is the double hit lymphomas. They are mature B-cell lymphomas, and here you have a recurrent chromosomal breakpoint activating multiple oncogenes, one of which being the MYC. Yeah, so you can have partnering genes, which is the BCL2 or the MYC1 or the BCL6 and the MYC, or it could be a triple hit lymphoma, and sometimes you can have other partnering genes as the CCDN1 or the BCL3 plus, the 9p13, which is seen in some unique lymphomas, and also you have other forms. But generally, the first 2 are the partnering genes that we commonly see, and very rarely we see the triple hit component also. So there are also the double expressor lymphomas where the protein expression is much more enhanced in these patients, and we must understand that while double hit lymphomas can be expressors, not all double expressors are double hit. In fact, hardly any are double hit. And we do understand that most of the double hit lymphomas you see in the germinal center B cell type, whereas most of the double expressors we tend to see in the activated B cell type. So it is about 5 times more common. Greater than two-thirds are non-GCB and they will not pick up the MYC BCL6. So you can, from this cartoon, it's a very popular cartoon seen in many of the talks that we come across. We do understand that there is the double hit component in these lymphomas caused by rearrangement between the BCL2 and the MYC and BCL2 rearrangement is quite a few, and most of them do not. It's almost exceptional for them to fall into the ABC subtype. And we know that the outcomes are the worst for double hit lymphomas, followed by the double expressor lymphomas, and followed by the germinal center B cell lymphomas who do not harbor the rearrangement. So can we identify the subsets who will relapse or not respond? So a good measure of DLBCL who relapse have a double rearrangement of the MYC and BCL2 called the double hit lymphomas. And the chromosomal breakpoint affecting the MYC 8q24 locus in combination with another recurrent breakpoint is seen over here. And other molecular abnormalities are a dime to a dozen, but the common cornerstone is the c-MYC overexpression and the BCL2 overexpression. So are there other components that will have a poor prognosis? I'll just rush through this. It's just there are antigens. There are a series of antigens which have been looked at in diffuse large B-cell lymphomas who have most of the time a shorter overall survival in these patients. Similarly, there are pathways which are overactive, especially the AKT, high AKT expression, older age, and also the CDK and 2A loss, and so many pathways which are overactive, which can contribute to a poor outcomes in these patients. And then there is lastly the oncogenes also that are important in having a negative prognostic impact in these patients, except for a few like the homozygous STAT3, which contributes to a longer overall survival in these patients. Most of the oncogenes tend to have a negative impact in terms of outcomes for this patient, but these have never been studied. One of the more elegant studies, which looked at almost 1,000 patients, 1,000 samples of diffuse large B-cell lymphoma from Dave and his group from Duke University, was looking at systematically to define a commonly occurring genetic mutation which is more than 5% in diffuse large B-cell lymphoma. And they tried to ascertain what is a connection between these common genetic mutations and how to prioritize the disease models and therapeutic development of DLBL. And this was an abstract which it was one of the groundbreaking abstract at ASH about 3 years ago. And they looked at all tumors were subjected to whole exome and transcriptome sequencing. And what came out of this was that there were a set of gene expressions that contributed to ways, that is the ABC, the high MYC expression and a high BCL2 expression. And 2 was the gene mutation, which included the KLHL14 and the CDKN2A to name a few, and a combination of some of the others which actually contributed. And when we looked at certain subsets, like a combination of features of the GCB and the EZH2, they had a favorable outcome in these patients. Similarly, the GCP and CD70 had a favorable outcome, whereas association of the BCL2 high and some other genes like the SBTBN1 tend to have a worse outcome. But these are just looking at correlation between partnering genes, which might allow for identifying subset of patients that might have a better outcome. So there is also the epigenetic mechanism. I'll just rush through this as one single slide. We do understand that as we go down in terms of relapses, the intratumoral methylation heterogeneity tends to come down. And methylation seems to have some sort of a protective role. And as we have, there is more of hypomethylation that happens. And as we go to a relapse setting, the amount of, so there may be epigenetic mechanisms also contributing to patients relapsing in diffuse large B-cell lymphoma. So can we perturb known pathways and mechanisms for resistance? And these have been tried to dimedicine without any significant benefit. One of the things that showed some promise was the use of lenalidomide, which I will allude to subsequently. So is resorting to alternate chemotherapeutic agents or using alternate monoclonal antibodies going to benefit these patients? The answer is largely no. So there have been various combinations that have been tried, including intensifying the therapy along with rituximab, using DHAP regimen, especially in patients with MYC rearrangement, etc. But there is a suggestion that probably that our DHAP regimen may have a better impact in patients with a GCB subtype who have relapsed, but we never look at this in the frontline setting. So, is intensifying therapy in frontline therapy going to benefit? The answer is a big no, wherein we looked at dose dense and dose intense therapy. The RCHOP 14 was not better than RCHOP. The addition of etoposide to CHOP also did not benefit, except for the French group, the RACVBP study, which demonstrated a better outcome for patients. But we must understand that when you look closely into that subset of patients, many of them belong to a good risk and lower stage disease. So the exception to the observation again is the GALA study or the RACVP study. And as I said, there were some criticisms to this because most of the patients who receive the ACVBP tend to be in the lower stage. Yeah. So, but looking at more intensive therapy, we all know about the CalGB Alliance study, which looked at infusional protocol and comparing with RCHOP. And unfortunately, this did not produce the results that everybody hoped that it would. But there were criticism for the study also in that it was not powered enough to pick up those subset of patients who might have benefited with the infusional protocol, and the subset analysis is going on, and still the results are not yet out. But largely, giving infusional protocol in diffuse large B-cell lymphoma did not score over R-CHOP. Similarly, can we add more medications to the standard R-CHOP and target certain pathways, which included targeting the NFK-kappa B pathway with bortezomib, targeting the EZH2 or the PKC beta with enzastaurin, and looking at EZH2 inhibitors, and also looking at BET bromodomain inhibitors for reducing the MYC overexpression by signal transduction. It was a big no, actually. It was a failed study. Most of these studies have actually failed to yield benefit. And the first one to go out of the window was the bortezomib plus R-CHOP regimen. The use of everolimus plus R-CHOP also fell through without any benefit for patients. And we have understood that. And the study which everybody thought might again show a benefit was the addition of lenalidomide to R-CHOP to improve outcomes in newly diagnosed diffuse large B-cell lymphoma. And this was the phase 2 study from the Mayo Clinic, which showed a benefit for the non-GCB subtype patients in terms of progression-free survival and overall survival. But strangely, at the same time, when this study was presented, the phase 3 study was also shown, which is a robust study, which was a randomized phase 3 study of lenalidomide plus R-CHOP versus placebo plus R-CHOP in diffuse large B-cell lymphoma. Unfortunately, this phase 3 study did not demonstrate a benefit for use of lenalidomide plus R-CHOP over R-CHOP alone. Similarly, using ibrutinib, we know that there is chronic BCR signaling in diffuse large B-cell lymphoma, and especially the ABC subtype. So this was one of the randomized phase 3 study, which was published in journal JCO, which looked at the Phoenix study, which looked at using ibrutinib in combination with rituximab plus cyclophosphamide. Again, you did not come across any sort of benefit for the addition of ibrutinib in these subset. There, in fact, if it actually influenced in a negative way the completion of chemotherapy for such patients with the standard R-CHOP arm because of toxicity. But when every time you look at subset analysis, and when you look at subset analysis, there was a tendency for better progression-free survival in patients who were less than 60 years of age, for patients who received ibrutinib and who could tolerate the side effects of ibrutinib, where it was used at 560 milligrams per day, along with rituximab. And there seemed to be a benefit for patients below the age of 60 in terms of progression-free survival, whereas it was detrimental to patients above the age of 60. So the study did not meet its primary endpoints in an intent to treat analysis in the ABC population. And as I said, it was detrimental for patients above the age of 60. What about the role of maintenance therapy? The REMARK study was what that explored the use of lenalidomide after standard R-CHOP in patients in the elderly population above the age of 60 to 80 who were untreated diffuse large B-cell lymphoma, given standard 6 to 8 cycles of R-CHOP followed by lenalidomide or placebo. So what came out of the study was that there was a suggestion of improved median progression-free survival versus placebo of about 58 months. I mean, it was not reached in the investigative arm, whereas it was 58 months in the standard R-CHOP arm. But there was no difference in the overall survivals in these patients. And the patients who were receiving lenalidomide did, as expected, have greater grade 3-4 neutropenia, and discontinuation were higher in this group due to toxicity. So elderly patients with diffuse large B-cell lymphoma who received first-line R-CHOP, the use of lenalidomide in maintenance may provide some meaningful survival, but they have to be picked and they have to be chosen very carefully. So is there more we can do for double hit lymphomas? We have had a host of studies. All we know very clearly is that the standard R-CHOP regimen is likely to fail these patients, and it is in these patients that you need to look at in more intensive protocols for treating double hit lymphomas. So there have been various regimens used, including the Burkitt's treatment that we use for Burkitt's lymphoma, which includes high-dose methotrexate, the Codox M-IVAC regimen, the R-CHOP regimen. But what has come out in terms of benefit consistently, at least in terms of better progression-free survival, is the use of infusional protocol with the dose-adjusted R-epoch. So intensive protocol helps in patients with double hit lymphomas in the frontline setting. And if you were to use intensive protocol, then these patients had a benefit in terms of progression-free survival over R-CHOP alone. And can we do a transplant for such patients? Well, if you have used an intensive protocol for such patients, then doing a transplant is not going to add to the benefit in these patients in the first line setting. So the current standard for double hit lymphoma would be to exercise the option of infusion protocol and also have some form of CNS prophylaxis, because we know that the incidence of secondary CNS involvement or CNS failure is much higher in the subgroup of patients. So there is an improvement in progression-free survival in these patients. And also, if you look at the BCL2 immunohistochemistry, which predicts worse outcome in these patients as against the BCL2 translocation negative, which has no impact on overall survival. Looking at the option of transplant in some patients with high risk features or high IPS score, looked at the role of transplant in frontline setting in CR1. But what it demonstrated, this was the publication from the British Journal of Hematology in 2014, which looked at a fairly large number of patients who underwent transplant in CR1. There was definitely an improvement in event-free survival, but as you can see, there was no improvement in the overall survival of these patients. So currently, there is really no role for subjecting a patient to autologous transplant in the frontline setting. So there are certain special situations that one would like to look at in diffuse large B-cell lymphoma, which includes managing early stage diffuse large B-cell lymphoma and addressing the CNS in diffuse large B-cell lymphoma. There are other entities which I probably will address hopefully in another talk, wherein for special situations, in how to treat special situations or special organs involved, like the testicular lymphoma or the primary mediastinal B-cell lymphoma, HIV-associated lymphoma, and the CNS lymphoma, which are distinct entities which needs to be addressed in a special way for optimum outcomes. So we will look at, I'll just address to this more recent study, which was published in the New England Journal and also presented in ASH 2 years ago, which is a flyer study, which looked at limited stage diffuse large B-cell lymphoma in terms of trying to abbreviate the number of cycles of chemotherapy for these patients. So the patients with untreated aggressive B-cell lymphoma from age 18 to 16 with stage 1-2 disease and IPS score, HS's IPS score of 0 and who were non-bulky were enrolled into the study. They were randomized to receive 4 cycles of R-CHOP plus 2 cycles of additional rituximab versus the standard 6 cycles of R-CHOP. So what came out was that there was no difference in terms of outcome. These were large studies, each included almost 300 odd patients, and there was no difference in terms of outcome. We also know that for limited stage disease, we may want to have a PET-directed therapy in these patients. So for those patients, who are PET negative, after 3 cycles of chemoimmunotherapy, we may avoid radiotherapy and go on to 1 more dose of rituximab plus CHOP regimen with comparable outcomes in these patients, provided they are PET negative. So the last aspect which I will address is the role of radiotherapy. I will just allude to 3 studies. One is a Recover 60 study, which showed that in those patients who did not receive radiotherapy, they had an inferior event-free survival, progression survival, overall survival, particularly in the elderly patients with bulky disease. So patients who have bulky disease, they tend to benefit with radiotherapy, but again, the data is, this was an analysis which looked into those patients who did not receive RT in bulky disease vis-a-vis those who did. But there is still debate over whether RT is going to add to a patient who have achieved a complete metabolic response to standard R-CHOP regimen. The Unfolder study also demonstrated the same picture, where early closure of the non-RT arm in phase 3 study, because there were a higher inferior event-free survival in these patients. The optimal greater than 60 patients evaluating whether RT can be spared in elderly patients also showed that patients with PET negative DLBL following R-CHOP or any additional therapy, for patients who are PET negative, perhaps RT did not contribute too much, but if they were positive, addition of RT improve the outcomes in these patients. So in conclusion, I would say that R-CHOP still remains the standard of care for most newly diagnosed diffuse large B-cell lymphoma, and this is unlikely to change in the near future. So prognostication at the molecular level has refined our understanding of diffuse large B-cell lymphoma. However, this being an independent of the IPI and can segregate worse subgroups, but the use of this information has not translated into better treatment strategies for such patients. Um, uh, uh, Targeting pathways may be of use, but with modest responses, and there may be some role to play for maintenance lenalidomide in older patients. And early stage diffuse large B cell lymphoma may be treated with abbreviated number of chemotherapies with comparable results. CNS prophylaxis in selected situation is recommended, and intrathecal therapy may be inferior to systemic therapy. I did not address this fully into the study due to the want of time, but it is something that we can discuss when we talk about special situations in high-grade lymphomas. So thank you for your attention, and I am happy to take any questions. Thank you.
Thank you very much, Hari, for very thorough talk about the management of DLBCL, especially the molecular classification. Yeah, and it's unfortunate that it's not really translated into a great change, sweeping change in the management, but probably that's what we may be looking at into future. The questions, there are a couple of questions which are been put in the chat box. You can have a look at them.
Yeah, I'm just trying to get off the, yes, yeah, sorry.
The first question is from Mahati. Yeah. What is the importance of IRF4?
So the IRF4, they identify a subset of diffuse large B-cell lymphomas which have a better prognosis. So patients with IRF4 tend to do exceedingly well with standard R-CHOP regimen. And that's what we understand in these patients, yes. Yeah. Right. And the next question I can read is, 3 important translocations by FISH. What additional molecular genetic investigations do you routinely do in your practice? Normally, we don't do any additional cytogenetic abnormalities. We tend to treat these patients because even if you look at many of the studies that have looked at the molecular determination of these diffuse large B-cell lymphoma in terms of choosing the treatment, it has not translated into benefits for these patients. So we do look at double hit lymphomas because from the perspective of wanting to give better CNS prophylaxis for these patients, and also we tend to use infusional protocols in double hit lymphomas. Besides that, it is purely a research tool and not for real-time practice. Yes. So, and the third question is, using PET-CT directed therapy in limited stage diffuse large B-cell lymphoma in published in Blood, good chunk of patients were post-resection and did not have evidence of disease at baseline. How can we apply the data to patients who have disease and in CR after 3 cycles? Well, it's a pertinent question, but that was a selection criteria for such patients. We have been trying to borrow a page from the Hodgkin's lymphoma story, wherein we can try to limit the number of doses for therapy. We know that before the advent of rituximab, when we gave lesser doses of, we gave only 3 cycles of the CHOP regimen, there were, even though they had a good immediate result, there were increasing number of relapses at 7 years and 8 years on follow-up. So your question is valid, that many of them, but we had to choose these patients, and and this study was designed for limited stage disease, and that is where we are looking at, and we cannot question that. Yeah. So what is your regimen of choice for CNS prophylaxis? I would currently increasingly the role of intrathecal therapy is on the way out, because it might be useful to a certain extent for leptomeningeal disease, but most of the time we have parenchymal disease, and intrathecal therapy will not do anything in these situations. So we probably need to look at some sort of a systemic therapy which has got CNS bioavailability, and that one drug is high dose methotrexate. And currently, even for testicular lymphomas and for most of the double hit lymphomas and those patients who have MYC overexpression, high MYC overexpressions, the choice is to use high dose methotrexate. Now, there are two ways of looking at giving CNS prophylaxis. One is to alternate between 2 cycles of CHOP with high dose methotrexate, or give the high dose methotrexate after completion of 6 cycles of R-CHOP. That is what we would resort to many a time in testicular lymphomas. But the most of the people would like to give high dose methotrexate after the second, the fifth, the second, the fourth, and the sixth cycle. So, and the dosing is usually around 3.5 grams per meter square, and 3 doses of high dose methotrexate is what everybody considers as sufficient for CNS prophylaxis. So, what is your age limit after which you administer R-mini-CHOP? So, there is nothing like, if any of you participated in about a month ago in the discussion of treating elderly patients with AML. I was one of the discussants. Well, in that, age is just one of the, as a number. You have to look at the frailty index in these patients and resort to looking at whether the patient is frail or not. And one must understand that, and the bottom line, the use of adriamycin wherever it can be used has its impact in terms of outcomes in these better outcomes in these patients. So if you don't use adriamycin, you are probably compromising the outcomes in these patients. And similarly, it is more doable to give mini CHOP in these patients. So what to come back to your question, what is the age group that you will use for mini CHOP? It is not based on the age itself, but actually the frailty index that one looks at to give R-mini CHOP. So a 70-year-old may not be tolerating a treatment that is going to involve an atria-based MACE therapy because of various comorbidities, and there we might want to use an R-mini CHOP, whereas an 80-year-old may be good enough to use an R-CHOP regimen. But those are all individualized, and there is no real standard that we have to use it in some.
There's another question
just based on cutoff region. Yeah.
There's another question just related to this. You can move on to that. Is in elderly, in which situations we can avoid anthracyclines? There's a question about that.
So we have to really consider, as I again repeated, you have to look at the frailty index in these patients. There are so many forms of index that can be used in these patients, of which some of them are what we call as so you have certain indices which have been standardized. I mean, I can't recall offhand. We have to refer to the book for that. And if they are falling below a frailty, it is better to look at to avoiding anthracyclines in these patients. And also, you have to look at what is the chances of the patient surviving and beyond a certain time limit. So if you think that the chances of him having a toxicity because of using the standard CHOP is high, you may come back and fall back on either reducing the doses, like using the R-mini CHOP, or replacing adriamycin with something like etoposide. So when you must understand that the outcomes with the CEOP regimen, though not up to the level of the CHOP regimen, is not far behind. So we may want to use that in these patients.
Right. Venkata has asked a question. In mandibular DLBCL stage 2 non-bulky 74-year-old IPI4. Apart from
Uh-huh.
CNS prophylaxis, do we need to give RT to mandible?
That depends again. So the rule of the thumb is, if you have bone involvement in lymphoma, it is always better to irradiate that. So if you have bony involvement in lymphoma, irrespective of what the response is, you always irradiate that. That. So in this case, if he has a mandibular involvement, you will want to irradiate this patient, irrespective of what the responses are.
Vinod asks a question about our limited stage DLBCL. The two studies, uh,
Yeah,
the S101 study and the
yeah,
FLY. So, which is the best
yeah.
way to treat?
Yeah, so it depends upon the S100 is actually using a PET guided approach. Yeah, so if what they have demonstrated is that if after 3 cycles you have a negative PET, you may just give one additional cycle to these patients, and the outcomes are similar. Whereas over here, they have avoided, in the Flyer study, they have completely avoided radiotherapy. Completely in these patients, whereas the S100 studies also resorts to it. For those patients who are PET positive, they have used radiotherapy as an adjuvant therapy. So it depends upon what you want to use. Both have got more or less similar outcomes.
Right. Um, so,
The last one is
yeah,
stage
just
3 testicular lymphoma, CR after 6 cycles of R-CHOP. Is it necessary to give RT to both the testes as a relapse risk? So generally the norm is to actually give radiotherapy to that is one of the standard practices, because the testis behaves like a sanctuary site, and we generally tend to give radiotherapy to the testis in these patients, because they even if you have removed one of the testes, an orchidectomy has done, the opposite, there is a 30% chance that the opposite testis also may harbor a lymphomatous, a lymphoma in the opposite testis too.
I think we have let this. Let's take a last question. It's about a 50-year-old female gastric DLBCL CD20 negative. I post chop partial response. What should be done next? Radiation or salvage?
So they said it's a CD20 negative. That's a rather unusual B cell lymphoma. So we have to really look at whether that we have to probably review the histology, because to have a CD20 diffuse large B cell lymphoma is rather unusual.
Yeah, SN
One
is
may
done
have
in
to,
3 institutes. Yeah, the 3 different institutions, and IC is still
yeah,
the same.
yeah. But certainly being an extranodal site, and if it is a locoregional disease, if the response has been good with the CHOP regimen, we will always irradiate these patients. We would always give, earlier we used to irradiate all extranodal sites, and in this patient, because we have only used the standard CHOP regimen, we would want to irradiate these patients. And also, we may want to give CNS prophylaxis also in these patients, because there is a high incidence of CNS, secondary CNS involvement in these patients. Yeah. And she's young, so we will definitely want to use the option of high-dose methotrexate as secondary CNS prophylaxis.
Right. Do you want to take one more question? Yeah, there's MS Kumar asks a question: how can we manage paravertebral soft tissue involvement in DLBCL with epidural impingement?
So generally, because they are chemosensitive diseases, we would consider starting with chemotherapy itself, because they tend to respond so well to chemotherapy, and because one of the sites which predisposes to CNS disease is a paravertebral region, we would also want to give CNS prophylaxis in this patient. We would want to exercise the option of radiotherapy only if there is really a life-threatening problem over there. Otherwise, most of the time, chemotherapy will work. Yes.
Yeah, I think that's the last question. Um, Thank you very much, Hari.
Yeah,
It was wonderful to have you with us. The students,
thank you.
I'm sure they have enjoyed the talk as well as the interaction and question answer session. I think that
Yeah,
this part of the talk is loved by all because the doubts are answered by the expert. Thank you very much for being with us.
thank you.
We hope
Thank you.
we have you with us sometime in future to talk about other lymphomas, B cell and the
Yeah,
T cell lymphomas discussed.
yeah.
Thank you very
Thank you.
much and good night,
Thank you.
everybody.
Thank you.
Yeah.
Thank you, Padma. Thank you very much. Thank you. My pleasure. Thank you.